While we're letting everybody come in, I'm just going to give a quick disclaimer. We do want to let everybody know that while this is going to be very informational and informative, this is not supposed to be a substitute for medical advice. So if you do have any specific questions, we do ask you to take those to your clinician, just to keep everything appropriate. But with that being said, I will go ahead and stop sharing and we can go ahead and get started. So today we are really thrilled to be joined by Professor Dr. Annemiek Dols and Noor Woerdman. Professor Dr. Annemiek Dols is a psychiatrist working at an acute inpatient clinic at the University Medical Center of Utrecht. Her research is closely linked to her clinic work in a focus on mood disorders complicated by somatic or cognitive symptoms, neuropsychiatry, and electroconvulsive therapy. She serves as a board member for the ISBD and is serving as a member of the ISBD Taskforce Older Age Bipolar Disorder and the Taskforce Targeting Cognition. Noor Woerdman is a junior researcher at UMCU, working under the supervision of Professor Dols. Together, they conduct research on tapering of mood-stabilizing medication in individuals with bipolar disorder, and they are studying a cohort of older individuals with bipolar disorder living without long-term secondary prophylactic medication. So today in this webinar, they will present findings from this cohort alongside results from a recent survey exploring patient experiences with tapering of mood stabilizers, excuse me. So with that being said, I will go ahead and hand it over to you guys. Thank you so much for being here. And then also we will have a quick Q&A at the end if we have time. So if you have any questions, go ahead and send those in the Q&A box and I will be looking through those as the webinar goes on. So.
Thank you very much. It is very great honor for me and Noor to be invited to have this webinar with you. As I said, as I was just introduced, my name is Annemiek. It's a very Dutch name, Annemiek Dols, and together with Noor, also very Dutch name, we will provide you with the webinar. Please let us know if you have any questions. So I have a few disclosures of the funding that I've received in the past for my research. And today we will talk about living with bipolarity without maintenance or relapse prevention medication. So as a clinician, I'm often faced with the question that is proposed by the patient, doctor, how long should I continue this relapse prevention medication? And I can understand that question because especially if people have been stable for some time or they age and they feel that they have more life experience and they gain more tools to deal with triggers, they are wondering about that. And I always openly discuss that with patient and relative to see what is the balance between the need to prevent the relapse, reduce the risk for possible suicide or suicidal ideation. And some patients say that they agreed with family and friends to continue the medication forever. So that can be an argument to continue. But then on the other side, there are, of course, the side effects of medication, the possible impact that they can have on physical health. Sometimes there is complaints of cognitive dulling or the feeling of less autonomous living, like you feel like you always depend on something that is not your own strength from inside. So with aging, I think it is associated with, yeah, you can show all of them, yeah. So as you can see, with aging, we see that there is an increase in cognitive symptoms. Some of them are normal with aging. Some of those complaints are like the prodrome of dementia, and some of them can be a side effect. And as you can see in the graph, the number of side effects increase with age. So sometimes people, even when they are on the medication for a very long time and they've never experienced any side effects, that might change when they age because your body is changing, your whole metabolism is changing, so also you may experience more side effects. Then a problem that we see with aging is that the life expectancy of people living with bipolar disorder is not as it is in the general population. So on average, it's like 10 to 15 years younger. And this is due to some unnatural causes like suicide or accidents, but mostly by natural causes like cardiovascular diseases, all kinds of diseases that might even be worsened by the medication that people are using for their bipolar disorder. And something else that changes with aging is the role that people have in society. A lot of patients, they tell me that with aging, they don't have to decide on a job or education or how to raise the children, how to find a partner. I mean, for some people, it's those obligations, they are not there, and then they feel that they can live more peacefully, so they have less triggers. So a question that is also asked in the clinic is, how strong is the evidence for relapse prevention? So this is a review that was written several years ago, to 2022, on preventing new episodes of bipolar disorder, and they did a systematic review. So in this review, there are 22 trials. In 13 of the trials, people were on one medication, and in 8 trials, people were on 2 medications or more. In those trials, 31% had a new episode within the 2 years when they used medication. That was a lot less than the 51% of the people that did not use any medication. So I hope this is very clear that there is like a reduction of risk for relapse from 50 to 30%. So as a clinician and as a pharmacotherapist, everyone would say, well, this medication is very effective. But when we wrote the guideline in the Netherlands, the patients that were in the committee to write the guideline, they said, well, but half of the patients without medication were fine. So we want to know who is that group, who is fine without the relapse prevention medication. So here you can see this is another study that is often referred to where people are followed up, like not in a trial, but like naturalistic, whether they continued or discontinued lithium. And they looked for, did they have any relapses? And in this graph, you can see that the upper bar, the line, the continued line, is the people who continued on lithium. And you can see that every time someone had a relapse, there is like one step down. So they were followed up for 6 years, and you can see that the people who continued on lithium, they have much lower relapse rates. Because in the lower bar, where they have the dotted line, you can see that there is more relapses. Most relapses occur within the first 3 years. After that, the difference between the two groups is not so big anymore. So you could imagine that for some people, this is a good idea. They don't have a relapse. And for some people, this is not a good idea because they will have a relapse very quickly. And we all know that sometimes it's very hard to recover from a relapse. So this is the Hamlet's agree, like how to manage discontinuation of mood stabilizers in bipolar disorder. So much is written about it because it is a topic that is discussed often between clinicians, but also with clinicians and patients. So in this graph, they try to explain the dilemmas. So for a specific, like for a group, we can like predict what would be the course, but a patient is not a group, it's an individual. And for the individual, we don't know what will be their course. Like, we're not psychic, we don't know what's going to happen in the future. So we have to deal with that insecurity. Then the effect of the medication on the course for that specific patient is also unknown. Like, I've worked at the older age bipolar disorder clinic for a very long time, and then sometimes people have been stable for like 30 years on lithium, and then you're like wondering, like, is lithium working very, very good, or is not needed anymore? You will never know for that specific patient. Then the cure may be worse than the disease. Some patients, they have so many side effects that they gain a lot of weight. It's very hard for them to move around. They get very depressed by that, and then you don't know what is worse, the cure or the disease. And then there's always it's in the guidelines, so the doctor advises it, and then it is hard for the clinician, but also for the patient to go against the guidelines, because then you feel if something goes wrong, well, what were you thinking? In the guidelines, the advice is to continue, and you did something else. So this is something that is, I think, more important for clinicians to realize. How do we view people living with bipolar disorder without medication? Because we often wonder if they have any insight in their disease. Are they do they take the medication? Do they even accept that there is something wrong with them? Or do they accept that something was wrong with them in the past? But I've talked with a lot of people who live with bipolar disorder or bipolarity that don't use medication, and they feel like it's not only a disease, but it can also be a superpower where they can be very creative and be very productive, very rich emotional life with deep empathy, and they don't like it if other people say that that is all disease. It can be very harmful, and it can be a very hard life, but it can also be like a superpower. So in the Netherlands, for those of you who don't know it, we are a very social country, and there are very few barriers to healthcare. So everyone is obligated to have healthcare, and if you can't afford to have any healthcare insurance, then it will be provided to you. So in our country, we did a survey in the general population, and we found that of the people who fulfill the criteria for bipolar disorder, only 40% is receiving mental health care, and only 38% of them is on medication. So that means that in the Netherlands, the majority of the people who fulfill criteria for bipolar disorder are not on medication and are not receiving any mental health care. So I was very intrigued by that. I was like, oh, maybe we have to look for those people and guide them to the mental health care. But later on, I was like, well, maybe they are surviving by themselves, and maybe I can learn a lot from them. So I need to find this group and listen to their stories. So we started this study, Bipolarity in Older Individuals Living Without Drugs, the BOLD study. And we did a quantitative part where we did the questionnaires to make sure that, is it a true bipolar disorder? When did it start? What is the family history? And so on and so on. And then we did a qualitative part where we did interviews on how did you decide to taper the medication, how do you survive, what do you do to cope with mood instability. So I think this case report is why I was invited for today, and that is that one of the people that I've met is John, and we wrote this case report together, and he's living with bipolar disorder, and he only takes the medication as needed. So he has olanzapine, and when he like sleeps very bad for several nights and he feels like the energy is coming up, he like sends a message to his psychiatrist, like, I feel the energy is boiling, so I take my medication tonight to have a good night's sleep, and I will report back to you tomorrow. And by this, I mean, it's not that he has been admitted, he has even been admitted involuntarily, but in between, and now for quite some time, his last admission was like 5 years ago, he is maintaining a good mental and physical health with this medication as needed regime. So when we look at the group, then I think it's good to see if this group is very different from the people that attend the mental health clinic. So we did a comparison, and I think that is going to be in the next slide. Oh, this is how we we had 104 people who said they wanted to join the study, but not everyone could be included. Some people could not be included because they were too young, or they didn't have a diagnosis of bipolar disorder, or that wasn't long enough ago. But actually, of the eligible people, 14 people refused to participate because they said, well, your study is still within the frame of diagnosis and bipolar disorder, and I don't like those terms, and I don't experience any bipolarity, or I don't experience it as chronic or lifetime, but I view myself very much as recovered, and I don't want to be engaged in having to fill out all those questionnaires again. So for 2 years, we collected data, and we found that this bold group did not have a milder subtype, because that is what often was said to me, well, the people that don't use medication, they have a milder subtype. But in fact, that was not the true. They had an earlier age at their first episode. They've had more episodes. They were admitted as often as those who were attending the mental health clinic. They had much more childhood adversity. And in the interviews, they mentioned that overcoming what happened to them as a child actually gave a lot of mood stability afterwards. So this is why they could stop the relapse prevention medication. The ones in the bold group had less current mood symptoms and had a much better social and cognitive functioning. So I see there are some questions in the Q&A. Do we answer that now, or like when I'm done with the presentation?
We can do them at the end. We'll hold, if we have some time, we can, go through them and answer, if that's okay.
No, I just want to make sure that I'm not like lost the whole group because something that I said was totally unclear, but you can see questions. Okay. So then what we looked at is like the people who are not on relapse prevention medication anymore, do they have like different coping styles or like different personality than the ones that are attending the mental health clinic? And we compared the two groups, and we found that the coping styles of the ones living without the relapse prevention medication was more active problem solving and less comforting cognition. So active problem solving, it is always hard to explain what it really means, but it's like you have a problem and you go at it. And this group has that style. When they are faced with problems, they dive into it. So it's not always the best way to do things in life. So it's not like one coping style is much better than the other. But this is how the type of person that in the Netherlands stopped their relapse prevention medication. So what do we want to do next? Of course, we want to compare those two groups in terms of relapse and survival, and maybe compare their physical health and their cognitive and social functioning. We, of course, have to analyze the interviews, the qualitative interviews. And we did only include people aged 50 and over, but we think we should include people across the lifespan, because of course it's not true that only people after the age of 50 have enough life experience to make decisions like this. And we want to prepare a discontinuation trial where we can see how we can manage that. And in preparation of this discontinuation trial, I think we did something that Noor is going to present, isn't it? Yes.
Yes, thank you, Annemiek, for the introduction. I'll just get my slides up. Yes, so can you see my slides now?
Yes, looks good.
Okay, perfect. So thank you, Tori and Annemiek, for the introduction. My name is Noor, and I work as a research assistant together with Annemiek. And indeed, the last couple of months, I've been busy with analyzing data from a Dutch survey we did. It was a survey on patient experiences with the tapering of mood stabilizers among individuals with bipolar disorder. And today I'll present our results to you. So I'll keep the background short because it kind of overlaps with what Annemiek already told you guys. So just a quick recap. In the guidelines for the treatment of bipolar disorder, both internationally as well as in the Dutch guidelines, the primary aim in the treatment is preventing new mood episodes, so preventing relapse. And this can be done through psychoeducation, through interventions aimed at self-management, or through pharmacotherapy. And today we'll focus on the pharmacotherapy part. So maintenance treatment is often seen as the cornerstone of relapse prevention, and the therapeutic goals of maintenance treatment can be divided among different domains. So we have the treatment of acute mania and acute depression, and the prevention of new maniac and depressive episodes. And medication that acts across these domains is often referred to as a mood stabilizer. And the term mood stabilizer is sometimes debated, but one common view is that a mood stabilizer should be effective in at least two of these domains. So, for example, in treating acute depression and preventing new depressive episodes. And as Annemiek just showed you, these mood stabilizers are known to be very effective in preventing relapse. Some of these you may also know as antipsychotics or anticonvulsants. I think lithium is probably the most well-known mood stabilizer. And we know they are effective for a lot of people in preventing episodes. But as Annemiek also already said, there's still not enough research or data to provide recommendations to people on mood stabilizers. So people who've been on mood stabilizers for 10 years, we don't know how long they should continue their medication. So currently guidelines simply state that medication should be continued indefinitely. And well, the study that looked at how many people with bipolar disorder in the Netherlands actually use medication. I have the other percentage here. So 62% of the individuals who participated in that survey reported not using any medication for their bipolar disorder. And another survey that was done in the Netherlands, it was a broader survey on the use and tapering of any psychotropic medication, so different types of pharmacotherapy. And they found that 84% of the respondents actually tried or attempted discontinuing or tapering their medication. And they said that this was mainly because they experienced adverse effects like weight gain or kidney problems, and because they had a strong desire to live without medication. So again, you see that there's a big gap for some people between what the guidelines recommend and what you see in clinical practice. So since we found that there is a group of people living without medication, we were interested in how these people were able to do so. So we developed a survey. It's a survey on patient-reported experiences with tapering of mood stabilizers, and in Dutch we call it SAS for short. And it's a survey that basically captures how people in the Netherlands tapered their mood stabilizers in the absence of clear guidelines. So we recruited people online, and 104 people responded to our survey. And we asked these respondents to fill out two different questionnaires. So our own questionnaire, the SAS survey, with questions on tapering, different schemes they used, reasons for tapering, and we included the FAST. This is a questionnaire, it's called Functioning Assessment Short Test, and it's a questionnaire on daily life functioning, and it captures things like cognitive functioning, interpersonal relationships, and leisure time. So it gives a broad overview of how people are doing. And we were curious to see how the people living without medication were doing in terms of functioning. So our survey group mainly consisted of female, aged approximately 50 years old. And the subtype distribution was unknown for half of the group. And for the other group, it was almost evenly distributed among type 1 and type 2. And we asked the respondents to report which mood stabilizers they ever used and which they were currently using at the time of filling out the survey, just to get an idea of which mood stabilizers were used most often. And we saw that most respondents used lithium at least at some point in their life, almost 75%. And it was followed by quetiapine and valproic acid. So just to get an idea of the mood stabilizer types that were used among our group. So as you will always see with surveys, not everyone filled out all questions. So on the whole tapering process, we have information from 97 respondents, and 77% of them reported tapering under clinician guidance. And 46% of the people in our group were able to completely discontinue at least one mood stabilizer, of whom 28, so 62%, were able to completely taper all mood stabilizer or discontinue all mood stabilizers. So they were completely medication-free. So there's also a part of this group who were still on another mood stabilizer, but they were able to reduce. Another 21% was able to discontinue to as needed, so the same as with John's case. They use their medication whenever they feel like it's necessary, and if they don't use it. 33% of the group attempted the tapering, but they were unsuccessful, which means they either had to add on another mood stabilizer or they were back at their starting dose, for example. So what we found interesting is that within this group, 66% of people, so almost 2/3 of the people, were able to reduce at least some use of their mood stabilizers. So we were also interested in how they tapered their medication. So I already told you that most of them were under guidance by a clinician, but we were also interested in if there were specific schemes they followed or not. And we found that the majority of the people tapered gradually, and there was only a small part of the people who just quit their mood stabilizers cold turkey, and they showed no tapering scheme. But most of them did it gradually. Unfortunately, it was pretty hard to figure out how exactly they did this. So in most cases, no real scheme could be identified, but for those for who it was, we were able to identify a scheme. We saw that most of them tapered using a linear scheme, and a few tapered using a hyperbolic scheme. And just to show you quickly, yes. So with the linear tapering, we mean that people use fixed steps. So every time they reduce their dose, it's with the same amount. And with hyperbolic tapering, bigger steps are taken at the beginning, and as the dose gets lower, smaller steps are taken. So we were curious to see if there was a preference, but we saw that most of them did it linearly, but again, a lot of information was missing. So the same was the case for the tapering duration. Also pretty hard to figure out the exact duration, but we saw a lot of variety here, going from a few weeks to a few years. So yeah, all we can say is that there's a lot of variation in the tapering schemes, and that there is no real golden standard which we found. So why did these respondents taper? So there were a lot of different reasons, and the three main reasons were first, adverse effects that were recognized by a clinician actually. So kidney problems, for example, and the second were more based on the individuals themselves. So they either had a big fear of negative long-term adverse effects, or a strong desire to manage their mood symptoms without medication. So kind of the same as what we saw in the two other Dutch surveys. So we also did a very explorative analysis on the daily functioning. So using the FAST questionnaire on daily life functioning, covering all the different domains. And while this is all very explorative and we can't really draw any conclusions, we were still curious to see how the 28 people who were able to become completely medication-free were doing, and how the people who were still using a form of mood stabilizers, how they were doing. So we cannot compare the two, but we just wanted to see how both groups were doing. So the FAST is scored in such a way that if you have a lower score, there's less impairment, and the higher the score, the more impairment there is measured. So for the people who were living without medication, as well as for the people living with medication, we found functioning to be pretty well. Again, it's very explorative, so we can't draw any conclusions, but we still thought it was nice to see that there were no drastic numbers here. So, of course, our survey has some limitations. Like I said, we recruited online, and this could also be an explanation for the relatively high functioning sample we see. It might be that people who are doing better are also more willing to participate in research and to share their story. Second, this is something you always see after analyzing the survey, but we did not really capture any information on illness history. So we don't know what the people look like at the moment of tapering. So we don't know if they'd been stable for a very long time or if they had just recovered from an episode. So that would be something we want to look at in the future. And lastly, which you will always have with surveys, is we only have data from one time point. So we, again, can't really draw any conclusions on, for example, the functioning. However, despite these limitations, we still think this survey again shows that there is a gap between the guidelines and real the real clinical world. Within our sample, we saw that almost 2/3 of the people were able to discontinue their medication in at least some form, either to as needed or reduce dose. And we also saw a lot of variation, which probably is due to the lack of guidelines. And there is no recommendation of what to do. So therefore, everyone just does what they think is best. So we hope and we think that our research serves as a stepping stone for future research. Obviously, we would want to do a large randomized controlled trial, but this is, of course, also hard to do. But we're currently busy with developing an English version of our survey. We've added some new questions and changed some things so we can capture even more information. And we hope to soon start distributing it in, for now, the UK and the United States, and hopefully soon also in other English-speaking countries. So we hope that maybe some of you guys will be able to provide us with even more information on tapering experiences. So I think that was it. And maybe we have time for questions now.
Can we already provide people with the survey? Can they participate?
Not yet. It's not live yet. So, but maybe we can share a link and maybe you can help us with distribution.
Yeah, absolutely. We might be able to include it in our next research newsletter. I'll check, but if not, we can, just for everybody watching, maybe we can at least upload it to the page that this recording will be hosted on our website. So yeah, for sure. I think that would be great just to get some more information because it seems like there's a lead there and definitely would be interesting to get some more data. So I saw, Annemiek, you answered a couple of questions. There are a handful. I see you typing for one of them, but yeah, we have a couple minutes if you guys want to take on a few questions.
Yeah, do you think any of those questions is important, like because some questions is like, I always wonder that too. How can you tell the difference between bipolar and ADHD? But
Mm-hmm.
I'm not an expert on that, so it's very hard to say something about it.
Yeah, for sure.
Yeah, so we
Nice.
will distribute the survey to the UK. We've been connecting with Bipolar UK and also with the USA, the Depression Bipolar Alliance. So we hope to reach as many people as possible to fill in the survey.
Yes. And we can, on our end, like I said, we can make that information available to everybody who's interested.
That
When
would be
it
super.
is, yeah, of course.
Do you
Um,
see a question that you would like me to answer, or Noor? There was
do
one
you
question
have,
specifically for
there's
Noor.
one that says, do you have any resources you would recommend to people with bipolar who are interested in tapering? Maybe don't know where to start.
I don't think we do.
Okay.
We just like pioneering. And I
Mm-hmm.
think the people living with bipolar disorder, they are way ahead with pioneering. And we clinicians and researchers, we are only catching up. So if anyone has experience with it, please let us know, because I think it's our obligation as researchers and clinicians to gather all the information and then see what is the common in all the experiences, and then give that back to the group. So I think we're at that phase at the moment. But I think a lot of, if you have a psychiatrist, then you can talk about it and they will help you and like personalize the advice.
Mm-hmm.
Um, uh, Yeah, I think one question here is that if you decide to try to live without medication, then the risk for mania mania can probably be more harmful than depression. Although depression can come with suicidal ideation, so it's hard to say.
Mm-hmm.
I think in the group that lived without medication, they also have some acceptance that no one is stable all the time. And if you accept that there is always going to be some instability and not panic about that, that also helps to maintain stability. It's like
Mm-hmm.
try to be relaxed when you're stressed, but it is important, I think, to try to balance that.
Mm-hmm. This one I feel like is interesting. Which specific medications have been used, I mean, successfully on PRN basis? Are there any medications that are kind of known to work better with this method, or is there not enough information?
So I think what a lot of people have is like a crisis management plan where you kind of say, like, if I'm going to orange or in red, then I need like sedatives to get a good night's sleep or increase some of my antipsychotics. So the people that I've talked to who don't use relapse prevention medication daily, they use that kind of medication as needed, like the psychotics and the sedatives, mostly aimed at good night's sleep.
Mhm. Mm, right. Feel like the rest are not as relevant. I don't know. Are there any more that stand out to either of you?
Um,
No, I don't think I have the knowledge to answer these clinical questions.
We should check out the Laura Delano.
Yeah,
Mhm.
I saw.
Yeah, so olanzapine is the one medication that is often used in this approach. And some people ask if like the superpower of is that if that is anecdotal or that's provide, but there has been a lot of research on that, and that is what has come up that the like the rich feelings, the deep empathy, the creativity, and the productivity that has been shown over and over again to occur more in people living with bipolarity or their relatives. Like it kind of runs in families then.
All right. Are there any last minute questions? Let's see.
Yes, not so much the metabolic treatments, but what I've noticed that the people who live without medication, they all find some kind of regime for themselves. That can be either with activities like swim every morning or long hike every day or certain types of food, but something that kind of uh, provides a rhythm in your life that is like stabilizing.
Mhm.
And I think some of the diets, the metabolic diets, they can do that too. Is that what was meant by John? I don't know. Yeah, I think that when the data that I present in the BOLD study, of course, those are the people who tapered for more than 5 years. So they don't feel like they are a success story, but of course, in a way, they are, because if you don't manage to live without medication for like over a year, you wouldn't be in my study. So it's not that it is always successful, but I think we have a job to define for who this can be a path and who should not try this. And like I see that in some of the comments too, that we need a more personalized approach in psychiatry where we say this is a good option for you because you have these characteristics of who you are and uh, what you dealt with before, and it is different for your neighbor. And now we have like a one size fits all. Yeah, that is also true. That in the Netherlands, the access to mental health care is, I mean, we have waiting lists, but it's all very well organized, and we're very densely populated. So uh, there's always a neighbor to watch out for you. Yeah, I think that also makes a difference.
I can speak on the DBSA support groups are great. That's
Yeah,
yeah, a resource that we recommend to people quite often. So definitely a good one.
yeah, we have a partnership with the DBSD,
Mhm.
DBSA. Yeah,
Yeah, they're great. Their support groups are really helpful. Eric, we if you go onto their website, the DBSA, it's the Depression Bipolar Support Alliance, I believe is what it stands for. They have online support groups for different groups of people, either with bipolar or loved ones with bipolar. And they're definitely really helpful. I don't know that they have in person anymore. I think they did for a while, but yeah, we are not affiliated with them, but they are an organization kind of similar to International Bipolar Foundation that has a bit more access to actual groups. Oh, they do have in person. Okay, good to know. All right.
And it's true. The Netherlands is a great place to live. So.
All right. I think we can wrap it up. Thank you, everybody, for submitting your questions. It was very informative. And thank you to the two of you for joining us today and for taking the time out of your busy schedules to share this information with us. It's really, really interesting and definitely something that, depending on the person, can work, I think be really life-changing. So yeah, we really appreciate you guys taking the time. Again, to everybody, if you joined late, this will be recorded and added to our educational videos tab on our website in a few hours. So if you want to go back and watch the rest of it, you totally can, or rewatch if you want to. And we will give some information once this study or the survey is available. I'll see if we can either put it into our research newsletter, or if not, we can definitely include it on the this site that this will be hosted on. So yeah.
Thank you. That would be lovely.
Yeah, of course. Thank you so much for joining us, and hope everybody has a lovely day.
Bye-bye.
Thank you.
Bye.
Bye.